Thanks very much. I'm back like a bad penny out here. So, second talk. What is chimney or stockle? Basically, these are stents which are placed within a branch vessel and extend parallel to the aortic stent graft. So that is what this thing is. So these are the typical pictures which are there of a chimney. You have they're called paragrafts, parallel grafts, endobranching, double barrel technique, all the names that you have, whatever one can think of. Now, to introduce this topic, basically, initially chimney was used as a bailout technique where you accidentally covered one major vessel, especially in case of renal arteries and all, and then you try to bail out, trying to get into that branch vessel out there and putting in a stent out here. So this was the choice of treatment that time. Subsequently, it became an alternative to branch stent graft devices, which were having major issues in terms of availability and the time which was required to get these devices out there. And another thing is now recent development which is there, it can be combined with hybrid surgery when you want to have multiple vessels which need to be taken care of. So how can you minimize the consequences with those ones? So this is what a picture of a chimney EVAR looks like, a periscope which is there. Normal pararenal aortic aneurysms are repaired with commercially available off-the-shelf devices which are there. The risk with open surgery is pretty high, and you have high morbidity and mortality because of the thoracoleprotomy that you have to do with these kind of patients. And if you have the expertise available, you have skilled operators who can do endovascular procedures and all, probably it makes life very easy. And you should have a combination if required, if you have facilities for open repair also. Just to show one anecdotal case out here, this is a patient, a young lady who presented with a large 6.5 centimeter aneurysm which was involving the renal arteries, and on top of it she had a major problem that her kidney function on both the sides, the DTPS scan, it showed a function of 16 and 22 milliliter on both the sides. So doing anything to the renal arteries, we were very sure that we are going to lose both the kidneys. Trying to revascularize both the renal arteries, either by surgical techniques or anything, we would have probably lost both the kidneys because of the procedure. So what we decided to do was basically hybridize the whole thing, where what we did was in first stage, we opened up the abdomen and did a SMA bypass in this particular patient. And then along with that, we basically combined it subsequently with a chimney procedure. This is just to show the endograft which is opening up out here. You cannulated the renal arteries. You put in a stent on the left as well as on the right side. Subsequently, did a balloon touch-up. And then you have all these balloons which are there into both the renals as well as into the graft. And this is what some of these pictures basically look like. You can see a nice, chimney out there. And along with that, it's basically the gutters over a period of time, as you call it, are the spaces between the main device and the branch devices which are there. They also tend to get filled up over a period of time. So this is what happens. This patient had initially a transient type 1A endoleak, but then following it up after 6 months and all, most of these endoleaks tend to get resolved out here. Now, certain situations, the most important thing in chimney is that you must have about 15 millimeters of sealing, because otherwise the chances of developing endoleaks and persisting endoleaks which can expand are pretty high. So subsequently, people like Armando Lobato and all came out with a new technique which was basically a sandwich technique, that when you want to increase the sealing zone, you can basically put in a stent graft on top, and especially when you're using multiple vessels which are going to be fenestrated or to be taken care of, revascularized, you can put in a stent graft on top and then land up your main device along with the branch devices inside this particular sac, and you come out with a good revascularization. You can complete the procedure as you can see in this one, and you have these branches coming right into the device, and which is called the sandwiching. To go on to a little bit of review of literature, basically there's an article which came in Journal of Vascular Surgery in 2011. From one center, they had about 21 patients, 4 single renals, 8 double renals, 8 SMA and renals, and 1 SMA, success rate 100%. 30-day mortality 4.8%, which is, I think, acceptable in case of a pararenal aneurysm. Another article which came in March 2012, 37 plus 35 patients out there, again technical success of almost 100% out there, and mortality is 0%. Journal of Endovascular Therapy, again of October 2010, 15 patients, number of chimneys 1, and you had success rate of 100%. In certain patients, you had these issues of renal stent occlusion and all. In one patient, you had a type 1A endoleak, which was managed conservatively during 1 year follow-up. In 7 patients, out of the 7 patients with a type 1A endoleak, only 1 patient required intervention. The rest of them all settled down. There were no ruptures, nothing of the sort. And again, in the renal stent group, again, there was nothing at all. So again, looking at these various pictures and all, technical success has been pretty good. These patients have been doing well. And the chances of conversion, again, are very low in most of these patients. So when you look at that, what is of concern in these patients, which is there is the long-term results of chimney stenting. How does the device interact when you're putting in one major device, a large device out there? Is it going to compress the branches which are there? What happens to the type 1 endoleak, which happens because initially there will always be spaces between the main stent and the side branches which are there. Is it likely to crush the stent out there? So how long is it going to be, adopted in all widespread? What is the adoption of these ones? To conclude, basically, you need to look at these procedures out here, and you need to extend the anatomical eligibility of endovascular aneurysm repair using conventional devices, because the major problem with fenestrated devices is, one is if you order specifically tailor-made fenestrated devices, one is the cost is prohibitive, almost three times the cost of a regular device, and it takes about 8 weeks for the device to be delivered to you. If the patient unfortunately dies during this particular patient, you lost a patient and you lost the cost of the device also. So this is one thing. Of course, my subsequent speaker, esteemed colleague, Dr. George Joseph, is going to talk about the tailor-made devices which are there off the shelf instead of the off-the-shelf devices. And you have those options which are available to you. Sandwich, of course, is a better approach where the more than 2 vessels are likely to be revascularized. And it may be a good option for patients with tortuous anatomy, as cannulation and fever may be a problem. It appears to have a similar mortality to open repair with less morbidity. And long-term durability and stent patency remains to be determined with these kind of stents and all. So that is what it is. Basically, I think chimney is probably a good option, or an option to, in places of where you don't have very, very skilled operators, you can even do a chimney instead of doing a fenestrated device. Thank you very much.
Can I have a doubt? Like when you're keeping chimneys towards the blood flow, like in the ascending aorta, then the flow into the chimney is good. But when you have to keep it below in the descending aorta where it is not against the flow, is there a difference in the occlusion rates?
Not really. In fact, sometimes you have to do a reverse periscope also, and the results are equally good for that matter. There is not much of a problem on that one.
It would seem that one of the biggest areas where the snorkel or chimney has worked pretty well has been in preserving hypogastric blood flow, where you put one branch down in the hypogastric and then bring it up into a limb of the endograft and have another limb going down to the external iliac. There, the endoleak rate has been pretty small, and the durability of that has been pretty fair. The problem with that particular construction is that you have to have 2 endografts of about the same radial force. Yeah. Because if you use a Viabond, for example, that has very good radial force, strong radial force, and you put an endologics graft that is ideal for doing this because it sits on the aortic bifurcation, and the limbs of the endologics graft are relatively unsupported, except for that fabric is not, it's a separate thing. But then their iliac extender has not much radial force. So if you put a Viabond coming out of the hypogastric and you put an endologics extension down in the external iliac, I'll tell you in a week you'll be back fixing that the external iliac limb will have been slowly crushed by the Viabond as it continues to expand. So you have to pick 2 devices. You try to find situations where the 2 devices are about the same diameter, and they have to be of the same radial force. Because if one has more radial force than the other, it overpowers it. But we've done a number of those hypogastric preservations with the endologics device, and after making a few mistakes, I tell you, I did that exact mistake of putting and have it shut down, and then I went and I picked up the Journal of Vascular Surgery. There was an article from Kajraj from Stanford saying, or out of the West Coast somewhere, now he's in research, Cassie saying that, you know, you gotta, don't do that. It's gonna bite you because the radial force of the two devices have to be about the same.
Yeah.
And so we've gone to do that, and it's worked out quite well. I don't have a lot of experience with putting them in the renals, the SMA, and the celiac, or the SMA in both renals. We've done a few. The problem with those cases are, and we have very sophisticated imaging systems and everything else, is that they really take a lot of fluoroscopy exposure. I mean, I'll show you some numbers on the Ventana device in a little bit while. You look at the fluoroscopy time, that's a lot of radiation, and I wouldn't want to be the guys that are doing that regularly.
Yeah. I think what is very important at the same time is getting your sizing right, because in this patients, when you're doing a chimney and all, you must have 20% oversizing. So if your aorta is large, because when you're looking at EVAR, the largest size of device that you have is 36 mm. If you have an aorta which is 31 mm, then probably that patient is not suitable for doing a chimney, because you need a larger device which is not really, unfortunately, available. So that's very important again.
Yep. I think one other little tip about that is, and Krause Ivanov was one who told me this, if you put your chimneys in the renals, or where you're putting more than one chimney in, if you make them so they're long and they kind of wind across, they don't just go in and go straight up, but they kind of
They always tend to go like this.
The chance of getting a gut or endoleak are much reduced if you do it that way.
Yep.
And he's very firm in believing that. He's done a lot of it.
Yep.
Is there a difference between a balloon expandable like Advanta graft
Yes.
and a self-expandable?
Probably when you're using stents like the Medtronic stent and all, which has got a much better radial strength and all, probably Advanta is a much better bet. Whereas when you were using the EVA, the excluder device, which was with Gore, probably the Viabahn works much better with that one, because they have a similar kind of a radial strength out there. So that's one thing which is there. Depending on the stent, the Cook device which is there, the Medtronic device which is there, has got a much better, much more of radial strength. So it's better to put in something like a Advanta V12 in those kind of situations.
We'll talk about it a little bit, but if you think about that the Nelix device,
Yeah.
sac sealing, that if you think of a different platform with just a big single stent with the
Yeah.
bag around it, it would be ideal for doing chimneys or periscopes with that. Just couldn't miss because
Yep.
seal right around it.
Right.
Thank you.
Thank you very much.